She didn't charge any. They said, she said, "But this is how much it usually is." And then, no, it's like dress more comfortable. I love that for your mom. I never. My mom is the same career and I didn't do it these ones.
Gonna be a little bit of a review, but because we are doing lung stuff, we're gonna start with this. So remember, there is a recorded lecture, it's about 40 minutes on the difference between laryngectomy, and what that looks like, and tracheostomy. So go back and watch that. You do have your trach case study, that needs to be turned in. I will give you another week to do that. So that is all part of the next exam. This is as well, and I'm pretty sure you have had lung cancer at some point, but I just want to touch on a few things because it all ties together. We know that lung cancer is a leading cause of death. And so we want to make sure we understand the differences. Okay, so the two kinds that we talk about are our small cell and our non-small cell. Okay, a lot of times it's the tumors in the airway and then they spread, right? That's what our metastases are. So our small cell are the ones that grow very quickly. They spread very early. And then our non-small cell have three kind of subsets. We know by now cigarette smoking, we're going to include vaping. Anywhere we have smoking, we're going to include vaping as well, because we're finding that that is not a safe alternative. We know that you can get secondhand exposure, whether occupationally or whether you're around a lot of chemicals. And then also we're finding radon, right? So that's what leaks, the gas that leaks out of the ground. If you spend a lot of time in basements or doing a lot of digging, you can be exposed to it. So we know primary prevention is keeping you away from smoking and those baby chemicals. And our secondary prevention is making sure we know if you are a high risk, that we are getting you those annual CT scans and catch it early, okay? In your book, there is a chart. Out of this, what I want you to know is just what are the most common, okay? So our most common is going to be our adenocarcinoma. And those are the ones that have the early mets to your brain, your bones, it spreads very quickly. And then our next highest one is our squamous cell, and that is more localized. Okay, so understanding the different kinds, but really which are the ones you're going to see the most. And then the thing to know about the small cell or the oat cell is that they are very aggressive, and by 40% of the time, by the time they find it, it is already spread. Okay, so depending on where it is, will tell you what kind you have, how advanced it is, and a lot of times they don't know they have it until they start to develop some later symptoms. So chronic cough and chronic bronchitis may seem like an incidental finding, but it may be an early sign. By the time they do end up having some respiratory conditions, pain in the chest, if they've got any difficulty swallowing, all of these are later signs that may have already indicated metastasis. Superior vena cava syndrome. Are you familiar with this? Is this anything that you've heard of? This is really important to know because this is when you've got some type of tumor or blockage on your superior vena cava and it causes congestion of the blood from the shoulders up. Okay, so this presents where you've got swelling, congestion, they've got some headaches, vision changes. Anything that's unexplained where they're starting to have symptoms from shoulders up, definitely think we need to make sure that there is not some type of a tumor causing that blockage. Okay, so if you have a patient who is having these weird symptoms, please don't kind of disregard it, kind of recognize that could be superior vena cava syndrome. In your book, it goes through all these different things. All of this to say, lung cancer does not stay in the lungs. It affects everywhere. Okay, we're going to talk about some of these things when we get to the endocrine lecture. But just know it can affect everything, including your coagulation factors. Okay, so it can put you at increased risk of clotting, put you at increased risk of PE.
On that last slide, are those, okay, so underneath like the black letters, are those the signs and symptoms of the purple ones that are?
Yes.
Okay,
Yeah.
I just want to make sure I understood that.
So the SIADH, the Cushing's, we're going to talk about those going forward. So I don't expect you to know all those right now. I'm just letting you know that it affects all the body symptoms. So basically, any of these symptoms, as you're putting pieces together with your assessment finding, just don't disregard lung cancer just because it's not in the lungs, is what I'm saying. Okay. Different things you can do. We're gonna talk about some of these tests today, something as simple as a chest x-ray or a sputum culture, all the way down to a thoracentesis or a PET scan. A PET scan is what we usually use when we know there is cancer and cancer is active and it's alive. So what they'll do is inject you with a type of solution, and then they will slide you through the scanner, and anywhere that that cancer is metabolizing, because it's alive, right, it's eating it, it'll actually glow. So we use those to not only identify current tumors, but to see if it's spread anywhere else. So if you ever hear a PET scan, that's what they're talking about. Stages of cancer, understand that everything cancer related is staged, right? And obviously stage 4 is the most aggressive. The only thing that we can do to really cure non-small cell cancer is surgery. And our goal of any lung surgeries, we want to take out the bad while preserving the good, right? We want to maintain as much functional lung space as we can, right? Because our whole goal is tissue oxygenation, right? In your book, it talks about all these different types of lung surgeries. I'm not going to go over them now, but I do want you to look at them. I want you to understand what's the least invasive, what's the most invasive, right? From taking a scope down the throat to take a look, to taking out a wedge, to taking out the whole lobe. So just understand there's different surgical education and different, what do I want to say, care plan diagnosis that go with all those surgeries. In your spare time, I want you to go through and look at these because these are kind of cool. So the top website or the top link goes to what a bronchoscopy is. And if you're lucky enough to watch one in clinical, they're pretty cool. So it's similar to like an endoscope, but it's actually going into the lungs. This one's actually really cool because it actually shows you somebody inhaled a push pin, like the clear, like, you know, little thing you put on a bulletin board. So this actually shows how they go down and the different tools they use to retrieve it. It's pretty cool. And then this last one is sort of showing you what's up and coming. So if you've seen one in a hospital setting, it's usually a person. This is a robotic kind, which it can go beyond those basic airways, and it's got little wires and coils where it can actually go down further into the lung. It's really cool. So in your spare time to kind of help put the pieces together, so you can go ahead and look at those. Again, here's a few definitions that match that previous slide on the different types of surgeries, okay? So this just spells it out a little bit. These are the ones I want you to kind of take a look at. And then when we're looking at lung surgery, right? What are we wanting to do pre and post-op? Part of your trach case study is, if anybody's watched those videos, there's some patients who have said, I wasn't really prepared. I didn't know what I was getting into. Nobody really explained it to me. So it's really important, especially with the lung, they're gonna have pain. They're gonna have shortness of breath. They may have chest tubes. They may have a temporary tracheostomy. So these are the things that we really need to stress with our clients and their families. This is what they're gonna look like coming back, right? These are some things, might be temporary, might be your new normal, but making sure that they understand. In addition to surgery, we know we use chemotherapy, right? If we can catch this early, a 5-year survival can be as good as 55% if we catch it. But only a very, very small percent are caught at the point where it is not metastasized. Again, if you have your patients that have prolonged smoke exposure, they're a COPD patient, they always have a chronic cough. They always are short of breath, right? So by the time we actually see some of those other manifestations, we might be too late. So that's why we encourage those yearly CTs. We can use radiation. A lot of times we do it for palliative measures, meaning we shrink it enough, we prevent that superior vena cava syndrome, we improve their quality of life, or we're using it to kind of debulk, to kind of shrink it as much as we can so that we can go in and do the surgery a little more easily. And if you don't remember radiation, if it's been a minute since you've done anything, there's a little box in the book that goes over some of the things as far as skincare and comfort measures and those type of things. Okay, some other things that we're looking at now are immunotherapy. So this is becoming kind of a standard of care. And that's where we use the body's own immune system to target those cancer cells. So we're not relying solely on the radiation or the chemo. We actually have some other things that we're doing. I don't expect you to memorize these, but when they end in the MAB, right, those are some of our new immune therapies. So it's not only lung cancer that's using them. And then this is another video link that can show you how it works. And I think it's really interesting, and they're having really good success with incorporating these medications. Our goals are effective breathing. We want them to live their life as easy as they can. We want them to be comfortable. And we have to, again, with any type of cancer or surgery, we want to make sure we explain it's okay to be breathing, right? Your loss of your normal function, you've got some new scars, you've got some new things, and we need to make sure that we're studying that as well. This is a video link on a lady who was told she had lung cancer stage 4, and it talks about how she went through the process of breathing, how she was really expecting to not have a long-term survival, and how she, thanks to immunotherapy and a few other things, is actually doing quite well and exceeded their expectations on her life expectancy. So there is a quick, super quick, show of lung cancer. Is anything in there absolutely brand new? Okay. If it was, that's okay. If not, we're gonna move on to something that probably is more brand new. And we're gonna talk about the pleural and thoracic disorders. Okay, so thoracic is anything in this chest area. And when we talk about the pleura, it's actually a space that's in between your ribs and your intercostal muscles and the lung tissue itself. So it's actually this little narrow space, and it has fluid in it, right? And what that does is decreases friction. So think of when you have a blister and you've got that that yellowish kind of sticky fluid that kind of goes in between the layers to lubricate. That's what we have in between, right? And that all helps to maintain that negative pressure where your diaphragm contracts, pulls the lungs down, the diaphragm expands, the lungs go up, right? That's how we breathe. So you can get different things that happen not in the lung tissue and not in the ribs, but actually in that space. So we used to call it pleurisy. Okay, my grandmother used to talk about how she had pleurisy, right? Or they call it pleuritis, and that's where you have an inflammation in between. Really painful to breathe, really sharp pain with a deep breath, just from being over inflamed. That can lead to, among other things, can lead to a pleural effusion. And that's where that normal sticky lubricating fluid that we have in that space starts to get bigger. Okay, and it can push against the lung and decrease the amount of space the lung has to expand. So we see that pleural effusion a lot with lung cancer. We see it with liver cancer. We see a lot of the body tries to respond to this invasive tumor, these invasive cells, and one of the things it does is it starts to create more fluid. So in the pleurisy or the pleuritis, it's very short. It's an abrupt thing. Maybe you've had a cough, chronic bronchitis, maybe you had pneumonia, and it just causes so much irritation. Very sharp stabbing pain. It does not impact your pulse ox. It doesn't impact your lung expansion. It's just really uncomfortable. And we just treat the symptoms, right? So anything inflammatory, we use an NSAID, maybe some mild pain medication. The important thing with that is to make sure they're not splinting, right? We want you to take deep breaths, even though it hurts. So this is really more of a nuisance, uncomfortable nuisance, but it's not causing a problem. Whereas the pleural effusion, as that fluid increases, right? We're normally at about 10 to 20. I've seen them take off liters of pleural fluid. So depending on what it is. We see this a lot, I said, with the cancer. You can have it with pneumonia, but you also can have a buildup based on some other chronic diseases. And again, the body, and I don't know the mechanics, but the body's response to this foreign or this chronic condition is to increase the fluid in the lungs. Our most common is heart failure. That's the most common. We talk about fluid in the lungs, makes sense. As the blood is backing up, right, in the capillaries, it leaks out, and then we've got this fluid in the pleural space. Okay? We can also get some exudate, which is I want to say, I'm gonna say pus, but that's the wrong word, but you know what I'm talking about. It can be thick, it doesn't necessarily have to be the fluid. And that is, we come from infections or the cancers then. Okay, we can also get blood, we can also get pus and lymphatic fluid. But just know that anything in the pleural space that is not supposed to be there, really is not a good thing. Okay, so with that, we're gonna have pain. We are gonna have some change in lung sounds. We're gonna have some change in our lung movement, because if that lung is not expanding, we could get kind of a one side that expands and one side that doesn't. And if you do percussion, you're gonna hear dull, right? When you percuss over the lungs with a deep breath, it should sound hollow because it's air. If you have a deep breath and you're percussing and it's sounding dull, that means you're going over something, fluid or solid. Okay. So if you look at a chest x-ray, you're gonna see this area right here, okay? This lung, nice and open, fully expanded. This lung is expanded, but not to this point, and that's because there's something blocking it. Okay. One way that we use to empty that out is a thoracentesis, okay? So we can do a CAT scan or an ultrasound. Right, most of the time we do these with ultrasound to make sure that we're in the right spot because the lung has different lobes. And what we do is we put a needle in, right? Anybody seen a thoracentesis? Okay, what position were they in when they did it? Leaning over, they're leaning over a bedside table a lot of times, and they do that to kind of open up the real estate, spread the ribs apart. And you can put a needle in there, you can remove whatever is in there, fluid, pus, blood, whatever it is, you can get it for a culture. So you can see what's causing it. You can actually put medications in through that needle if you need to, or you can just be removing the fluid or air. It can be done as an outpatient. I've seen it done in the ER, I've seen it done on the floor, actually, if the patient is stable enough. And they bring in the bedside ultrasound and they go ahead and perform it. Okay, so let me pull up a video and show you what to do. It'll let me. I'm gonna fast forward. This is just them setting up everything they need.
With protective sheath and closure cap proximal end. The sterile trolley contains cotton swabs for chlorhexidine and skin disinfection and sterile drape, sterile ultrasound probe cover and gel, syringe and needles for infiltration of local anesthesia, pleural drainage kit, and on the left side there is a suture kit and gauze pads. Now we prepare the antiseptic solution, put it directly on the cotton buds. Apply aseptic skin prep widely around the insertion site and allow 3 minutes to dry. Start from the center and move out. Never come back to the center.
And your protocol at different facilities may be, different type of antiseptic or aseptic, whatever.
Once that is done, we drape the patient. We use the fenestrated drape first. Your mark is in the center of the window. The second drape is used to set up nice big sterile area. Insert the ultrasound probe into the sterile cover. Apply sterile gel on the probe and tie it with rubber band. Then reconfirm the position of the marking with ultrasound. Check the expiry date and draw up an anesthetic agent.
Okay, so it gets that all drawn up. We're gonna numb it first.
For infiltration of pleura and periosteum, use green needle. Always apply negative suction before injection. Once you are in pleura, withdraw the needle slightly and slowly inject the local anesthetic when the needle is withdrawn. Allow at least 5 minutes for local anesthetic to work. Use the blade to make a nice wide track for the pleural set insertion. Enter just above the lower rib to avoid the neurovascular bundle. Insert puncture needle and confirm the position within the pleural space by putting the catheter inside the pleural cavity. Remove the puncture needle and clamp the catheter before attaching it to the tubing system. Ensure all drainage holes of the catheter are completely within the pleural cavity. Then you can start draining.
You see the color of that fluid right there, see how it does, it looks just like what's inside of a blister, right? So there's different ways, once they do this, they can either collect it in that drainage bag, or you'll see the big empty bottles, the glass bottles that they can use. And when you notice the glass bottles, because it's coming through and kind of swirling around, you're gonna see lots of bubbling, right? Because that substance is very high in albumin, which is a protein, okay? So when you draw it off, you're gonna see all sorts of bubbling in there. There will be a minimum, or I'm sorry, a maximum of what they can draw off. Because if they're drawing off a certain amount, we are now pulling that out of the circulation. So you'll see some people that they pull off 1 liter or 2. You'll see some people that are chronic that they pull off 3 liters. If they pull off a certain amount for a patient and they don't tolerate it, the next time they go in, they'll make sure that they don't take as much off. So our job as nurses, number 1, is to make sure that we are looking at the patient, that we are educating them on what's going on, because you can see that's a pretty invasive procedure, right? To us, it's not, because the patient's awake, but we would need to explain what's happening, the positioning. We want to make sure that we are doing our monitoring, right? We want to make sure we have their good pulse ox. And if they're complaining of anything during it, we need to make sure that we're explaining what it is and communicating with the provider. So we want to limit 1,200 to 1,500, so that would be 1 of the liter bottles to 1.5. That is for our very first patients that we do this on, okay? If it's somebody who's had it routine, because once you drop that fluid, if there is a disease process, there's a good chance it'll come back. So until we know if their cardiovascular system can handle it, we want to limit what we're taking off. And because of where we're at in the lung, there is a risk of a pneumothorax or collapsed lung, okay? We need to make sure they understand that. Once we pull off some of that fluid, we're gonna send it down to the lab. We're gonna look and see what's in there. We're gonna culture it. We're gonna see what's happening. And then that will give us a better idea of how to treat, okay? It's really important that they are in high Fowlers, again, leaning over, so those ribs spread apart. We have to make sure they understand they have to be still. They cannot be moving around. And we want to be with them. We don't want to just kind of stand back with the provider. We want them to be able to see us. We can kind of coach them through it. Okay, monitoring what's happening. We have to look at their vital signs. their oxygenation, but we're also doing our assessing. What are they looking like? Are they in distress? Are they cyanotic? Are they conscious? All those things we have to make sure we're looking at throughout the procedure, because again, heart, lungs, everything's right in here. Our vital signs might be a late sign something's happening and we could catch it earlier. Okay. Once we are done, we want to make sure that they are taking some deep breaths. Not when the needle's in, not when they're performing it, but when they're done, we want them to take some deep breaths and re-expand that lung. Okay, we want to make sure that we're looking for bleeding, we want to listen to the lung sounds, make sure that they're all covered up, and then we get a chest X-ray, right? Even if it went beautifully, there might be a very small pneumothorax that we want to keep an eye on. Okay, so no deep breathing, no moving during the procedure, but afterwards, we're encouraging that. They also may have some discomfort as they're deep breathing. We call that re-expansion pain. So if they're having some chest discomfort, that's okay. We want to make sure it doesn't get any worse. We want to make sure it's temporary. If they're complaining of something more involved, severe chest pain, crushing pain, unable to catch their breath, those are things that are not normal. Okay, but it's having some discomfort with the first few breaths, that is normal. If they do have a collapsed lung, so if for some reason when they puncture, they accidentally, we call that dropping a lung, right, or collapsed lung, and that is we have disrupted the way the lung is able to expand, and now we have air that's leaking into that space. So we fixed one problem, maybe we took out the fluid, now we have air. Okay. And in the chest tube lecture, there's a little micro 20 minutes maybe micro lecture I want you to watch before you come to lab tomorrow. We're going to go over chest tubes because they are what we use to fix pneumothorax. Okay, so there's all different ways that you can get a pneumothorax, but that's what it basically means. There's air in that space. It can happen spontaneously, right? Very tall, thin, especially men have a risk of spontaneous pneumo. It can be related to the lung cancer or lung disease. It can be trauma, right? Those crush injuries that we talked about way back when we did the mass disaster stuff. Or it could be what we call iatrogenic, which is we accidentally caused it, right? It happened because of something we did. The spontaneous one, again, it can be due to something, or it could be we don't really know. Okay, again, tall, thin, especially guys in their 20s and 30s, if they're a smoker, they have a family history, that's where we see it. All of a sudden, they have pain in their chest, they come in, I don't know, feel like I can't catch my breath, it kind of hurts, we do an x-ray and boom, we don't know why, but they have pneumothorax. A lot of times, the sac's gonna be pretty normal, unless it is a reflection of another process, right? So these spontaneous pneumos that collapse, they're usually able to keep their sat looking okay. They may have some different breath sounds based on how big of a pneumothorax it is. And they might be complaining of some pain or chest discomfort, maybe some shortness of breath. When we say asymmetrical chest movement, it's got to be a pretty good sized pneumothorax for that to happen. Because remember, you've got 3 lobes on your right lung, 2 on your left. So it could just be in one lobe, right? So it can be a small pneumothorax and you're not going to see a difference in how your chest expands. It's got to be pretty big to see that. Okay. A traumatic one, that's where we're going to see our crush injuries because the steering wheel. We have a CPR. If you've ever done CPR, you're going to break ribs. It's just a given. And one of those ribs could break and pop into a lung. Okay, so we call those blunt or closed, right? That all happens without breaking the skin. We also have penetrating. That is where something disrupts that negative pressure system, whether it's a stab, a gunshot, some type of breaking the barrier of that pressure, causing an open wound. Okay, if you have somebody who is in a traumatic situation, maybe a car wreck, and they look okay on the outside, we still have to make sure we're doing a pretty good assessment, because if it's a pneumothorax, some breaths, they're able to breathe for a little bit, but every time you breathe, air is then escaping, right? So every time they breathe, there's going to be more and more. So they could look okay at first, and you're more focused on other injuries, but we have to make sure we take a look if there's complaining of increasing shortness of breath. Okay. there is a pretty good collapse caused by some type of a trauma, you are gonna see a little bit more of the lack of movement on one side. They may be hypoxic, they may be cyanotic. And it's gonna keep getting worse until you fix it. All right, so sometimes you're gonna see a hemothorax as well, especially if it's a trauma, something happened, right? Maybe the CPR also damaged some vessels, or when they had I had a kid who came in with a wound about maybe an inch, maybe, and it was right here on his chest. He was talking fine, he was moving fine, and as we watched him, he just started to decompensate. That little tiny wound was caused by a knife this long, and we only saw this little tiny entry wound, and we were like, okay, so he's got this little laceration. Not until we did a further assessment did we realize it had pierced, you know, all the way through. So there could be some bleeding in there as well. He didn't want to tell us he was stabbed, by the way. We were not like ignoring him.
So with a pneumothorax, are they more likely to have another one, especially like the spontaneous ones? Is it just?
And you have a spontaneous, you mean if you're like just no rhyme or reason, yeah, once you have one, you can be at risk for having another one. So if it's unfortunately until you kind of outgrow it or the body changes, what they can do is if you have repeated spontaneous pneumo, they can actually go in and they can actually inject, like a thoracentesis, they can inject a substance that will diffuse the lung to the inside of the ribs so that it decreases the pleural space, but it hears it so it can't. So there's different things that you can do if it's repeated. I did not pull up all my links. One of the things that you will see very commonly in these pneumothorax is subcutaneous emphysema.
There are 3 simple changes I tell all of my arthritis patients to make. Number 1, you have to start drinking more water. You wouldn't believe how dehydrated most people are. Number 2, you need to make a decision to take matters into your own hands. That's not.
Hello, everybody. Dr. Carlo Oden with Dr. TV. In this patient, you can see me pushing on his chest wall and gives out like there's a balloon, like a little air balloon, because this is subcutaneous emphysema. This is air stuck in the actual tissue of this patient.
So what that is when the lung has collapsed, right? There's an opening. So as that air is trapped in that pleural space, depending on what's causing it, that air can actually escape and go underneath the skin. And you will have this swollen area that where you press on it, you can hear the guy kind of grunting because obviously, right, he's got some trauma going on in his chest. But when you press on it, imagine a Ziploc baggie that has Rice Krispies in it, and you put it on the table and you press, right? That's exactly what this feels like. So if you ever have a patient come in and they've got a little blip, right, a little pocket of something, it usually is toward the top, right, because air rises. But if you see a little pocket and you press, that is a finding that you definitely need to pay attention to, because that sub-Q air, that sub-Q emphysema tells you that there's leakage from somewhere in the lung, and we need to identify where that came from. Anybody ever seen that before?
My husband has told me about it and.
Okay. Yeah, it's not a good finding, that's for sure. Make sure I'm sharing the right screen. Yeah, so once you see it one time, you will be like, oh my gosh, that's crazy, and you will never forget it. So we call it crepitus is the other word for that. So if you ever see this word, that's the assessment finding. So when you go to click on your little Epic box and it gives you all these different findings, right? If you ever wondered what that box is, that's what it stands for. So if we accidentally do it, which we know that there's a chance, that's why they sign their little consent form, there's a risk of, we could do it during central lines or thoracentesis, or maybe we're going in to do a biopsy. Usually it's a pretty controlled environment and we know what we're doing. Tension pneumo, did we go over these yet when we did the crush injuries? Okay, if what if we have that air in the space, right? So again, think of actually I have a really cool video, it's a goat lung, but I don't wanna gross you out. But so if you have a baggie, right, with air in it, and then you stick that inside another baggie with air in it, right? So as we squeeze, if there's a hole in that inner bag, every time you squeeze, air is gonna go from the smaller bag to the bigger bag. And over time, as you squeeze it, it's gonna get harder and harder to squeeze the bag, right? Because there's all that extra air. So over time, what happens is if you have a collapsed lung, every time you take a breath with a tension pneumothorax, a little bit of air is squeaking out, leaking out, leaking out. What happens is over time, that air pressure on the outside of the lung causes it to collapse. And then as you're breathing, it still expands because we've got the other side. So it will expand to the point where it pushes your trachea over. Okay, and it actually will compress the heart to the point where your heart stops. So a tension pneumothorax is a huge medical emergency. And I always see these on like Grey's Anatomy or House or Chicago Med or whatever. They always take the needle and they stab it in their lung and then all of a sudden the people breathe again, right? We've all seen this. And that's basically what you do. You take a spinal needle or a needle that's 3 inches or more long. And what you're gonna do is you're gonna feel on the ribs and you're gonna find that spot, you're gonna pop it in and you're gonna hear psh, and all of a sudden they're gonna be able to take a deep breath again. So that's one of the few times what they do on TV actually is what we do in real life. Not quite as dramatic and but that's what it is. So when they come in and they're having shortness of breath, if there is a chest injury, we've got all these assessment findings, right? It always starts with assessment, but if when you're doing it, you're noticing like, hey, their chest isn't symmetrically expanding, then we look a little further and we see the trachea is starting to move, you're having increased harder time breathing, and then we start to see our blood pressures dropping, our venous distension is happening. All of these are signs that we've got to do something really quickly. Okay, so all the things we normally see with the pneumothorax, and additionally, things that are showing that everything is getting compressed and crushed by the air that is escaped. Okay. I will show you a video of this if you bear with me here. I don't know why this is one they always show on all the medical stuff. I guess because it's really impressive. Okay. So this guy, this Larry Mellick, is his, he is an ER physician and he gets permission from his patients when they have something that happens to go in and video it and then he narrates it and then he puts it on YouTube. So they have some really crazy things, but this is a tension pneumo.
Saw some air come back.
What they're trying to do is find the area where the air is.
Tubing with a light tank.
So I'm actually will be working for air in that line as opposed to coming off like that.
There you go. No, I guess.
That's the big effort.
All that.
You know.
Getting good.
See the air bubbles coming up through? Now, if you look at this, you're gonna notice there is fluid in the syringe, there is fluid in the tubing. Why? Why, when they're accessing the tension pneumo, when they're accessing the air, do they have fluid in it to begin with?
Because of the fluid in the pleural space, they have to go through.
Is it to ensure that?
Push more air in?
Exactly. So when we talk about chest tubes, okay, our chest tubes are gonna have a water seal. Because as we are trying to subtract air, we want to make sure that air doesn't backflow and cause more problem. So when we have the fluid in there, it allows us to pull back, pull the air out, and then there's no chance that the air is going to go back through the tubing. So this is basically what we're going to talk about tomorrow with the chest tubes, is the water seal, meaning we get it to come out, but then we maintain that negative pressure so that it can't accidentally infiltrate back in. Okay, this is way more controlled than the fun like trauma where you pop it in and it like makes a big psh sound, but you get the idea, hopefully. Any questions so far? Okay. There's also other videos you can watch in here if you want, that are the animation kind that kind of bring it home a little bit, but I want to make sure we have time to get to the other stuff. So when you are dealing with a pneumothorax, you obviously are going to be paying very close attention to their oxygenation. You're going to get those ABGs. We're most oftenly going to use a chest tube, and depending on where it is, you may have more than one, right? Depending on which lobe of the lung, you might have more, like you can have 3 on one side and 2 on the other if you need to. What we were talking about was that pleurodesis, that medication that you can go in and adhere it to the side of the chest so that it doesn't happen to collapse again if you have repeated spontaneous ones. There's a thoracotomy procedure they can do too. Same thing. They go in, they cut a little window, and they make sure they adhere that one spot so that it doesn't collapse. Okay. This is where we're gonna end here. And I want you to watch the little micro lecture that talks about the different types of chest tubes, what all those different things mean. Because when you look at a chest drainage system, it's kind of intimidating, right? It looks super scary, the thought of it, there's a tube in the lung. But once you break it down to each section, it actually is very easy to do, easy step-by-step instructions, and you can set it up in about 30 seconds. So, not terrible. Okay. Questions on those 2 things? So you got one lecture on the laryngectomy versus tracheostomy. We've got a little bit on lung cancer to review. We've got this on pneumothorax and pleural spaces to review, and the chest tube. Okay, so all of that goes together. Then we're going to get into this next topic. I'm going to give you a break first, which is all of the advanced airway. And I will tell you, this is where, if you need to go get the energy drink or wake up, or whatever you need to do, you really need to pay attention, because this is the basis of your critical care, our oxygenation. So we're going to go over acidosis, alkalosis, we're going to go over vent settings, all those things. Okay, so I'll give you about 10 minutes to wake up, go stretch, get your mind clear. Okay. This comes out in chapter 37. If you look at chapter 37, we're not doing the whole chapter because this is the same med search book that you've been using. We're going to focus in on these pages right here. I know some of you don't have the pages, but in chapter 37, 1371 and 1389, not a lot of pages, but a lot of information. Okay. So when you're looking at where to study, it is right focused in this one area. Okay. Here are the things that we have to kind of establish. We're all going to agree that these terms are important. So we're talking about ventilation. That is when we move air in and out of the lungs. When we talk about diffusion, that is where the movement happens right between the alveoli and the capillaries. Okay, so this is where the exchange happens. We can't control that. That's done at a smaller level. And then perfusion is where the heart actually pumps oxygenated blood, and that's how oxygen gets to the tissues. Okay, so here's the 3 things that we need to all kind of remember, because we're going to talk about ventilators, we're going to talk about oxygen delivery and all that, but start here. Here's some other things I want you to remember. When we say the word hypercapnia, that means high CO2. When we say the word hypoxemia, that means low O2. And when we talk about hypoventilation, right? Ventilation is breathing in and out. Hypoventilation is when our breathing is not meeting the body's needs. Okay, so those are the terminology that we're gonna use. So keep that in the back of your mind as we start to explain. So respiratory failure, right? We talked about the lungs through most of nursing school. We know they're super important. We know we assess them. Respiratory failure is when the lungs cannot oxygenate the blood. And they also can't remove carbon dioxide, right? So as we add the oxygen, we gotta take something away. And when that happens, that balance is disrupted, we have issues. So this can happen from a couple different things. Hypoventilation, the body's not able to breathe in and out enough. There's something getting in the way of our gas exchange. Or as we're breathing, that oxygen's not getting to the tissues for some reason. We call that ventilation perfusion mismatch. So any of these three conditions will cause respiratory failure. With me so far? We're gonna do lots of thumbs up. So when we talk about acute respiratory failure, right? If we're talking about a ventilation problem, a body breathing in problem, we've got all sorts of things. We've got our asthmas, our COPD. We just talked about pneumothorax. It could be something that is a muscle condition like multiple sclerosis or Guillain-Barré. It can be a brain problem that's making you not breathe. It could be something stuck in the middle. All of these have to do with you can't breathe in enough air, right? Then we've got an oxygenation problem or a diffusion problem, right? So this is for whatever reason, the oxygen is not getting into the tissues, right? It's not diffusing at the cellular level. So if we have COPD, if we have pulmonary edema, if we have hypoxia, if we have low hemoglobin, low oxygen carrying capacity, those are all at the kind of smaller level. Okay, there's also a table in your book if you want to take a look at it. But bottom line, respiratory failure is we cannot get the oxygen where it needs to be. We're not adequately ventilating or oxygenating, right? So when we have our respiratory failure, that's what they need. And most commonly, that is COPD. Most of our patients that have acute respiratory failure, that need to be put on the BiPAP, that need to do whatever, is a result of a chronic lung condition, most commonly COPD. The thing with them is they, on a good day, have an ABG that's off. On a good day, we have those barrel chested, we've got our pink puffers or our blue blowers, and they always look a little funky. So we can't count on that as our only indication that they're in respiratory failure. We want to look for an acute drop in their normal O2 levels, whatever's normal for them, and an acute increase in their CO2 levels, whatever is different for them, right? So that's how we take a look at respiratory failure in a chronic patient. So acute problem that is a worse name of chronic. You got me? Understand I'm getting there. Okay. So we use ABGs on a typical day to try to figure out whether the problem is metabolic or whether it is respiratory, whether it's acidotic or alkalotic. So if you're somebody who's always struggled with ABGs, this is my favorite way to kind of set up your table. So we know that 7.35 to 7.45 is our normal range for our pH. Anything on this side that's lower is acidotic. Anything on this side is alkalotic. Yes? Okay. Anything with our CO2, normally we write 35 to 45 and then we flip them. My favorite way to read an ABG is when I make my chart at the top of my paper, I flip my numbers. Because in my brain, it doesn't make sense to me that, oh wait, 35 and lower is alkalotic because 35 and lower on pH is acidotic, and that makes me confused. So I just automatically flip those two numbers, and I know everything on the left side of my chart is acid, everything on the right side of my chart is alkalosis, and then it's much easier for me to interpret. So if you're somebody who always has kind of struggled with like, oh wait, I think CO2 is backwards, set it up that way, and you don't have to do any more thinking. So just a little helpful hint. So our normal O2, we don't really look at when we look at ABGs, but if we have somebody with respiratory failure, it's not enough to know whether they're acidotic or alkalotic. We also have to look at their oxygen. So normal is 80 to 100, anything 50, 60 or below, we know is respiratory failure criteria. So do your ABG, but also pay attention to that O2. When it comes to your CO2, remember, we flipped those on the chart, right? Anything greater than 50, anything greater than 45, 50 over here is acidotic, and that is also a measure of failure. So remember, it's not enough to just get oxygen in the body, you gotta take away the carbon dioxide. So both of those are gonna happen during failure. Okay. In addition to our ABGs for our acute respiratory failure patients, we can do a chest x-ray, we've gotta do an EKG, we wanna make sure it's not a heart problem. We're gonna get them on some hemodynamic monitoring. Tell me some two hemodynamic monitoring devices. A-line,
No, the pulmonary wedge pressure.
pulmonary wedge pressure. CVPs, yep, all sorts of things. So all of that we talked about at the beginning, we're gonna use to hemodynamically monitor. And tidal CO2, who's heard of that? And tidal CO2, Emily's got it. What is it? You just heard of it?
Well, when I was in the ED yesterday, or whatever day that was, Monday, she showed me that they, like, in the ER, they put a mask on them that's got this special.
Yeah. It's got a sensor.
Yeah.
So we measure the oxygen going in, but we can also measure the carbon dioxide coming out. And we've got to remember both sides of that coin, right? I know we always think oxygen, but we also have to start thinking carbon dioxide as well. So if they are in respiratory acidosis, so we're looking at this, our pH is going to be on the acid side, our CO2s might be on the acid side, bicarbs on the acid side. So with that, we are going to have low pH, high PCO2. A lot of times that means that the oxygen is also low, which also means your SAT's probably low as well. We know that there's probably retention of CO2, that's why the number's high, right? Here's the reason why. Here's what could be causing your respiratory acidosis. We have hypoventilation. We're not breathing enough to get the oxygen in and get the CO2 out. When does that happen? We have an overdose. We have somebody coming out of surgery. We have a seizure patient that is sedated, right? Respiratory depression can lead to respiratory acidosis. Another thing could be an airway obstruction, right? It could be something like I aspirated, I could be choking, could be my COPD's flaring up and I can't get the air in, okay? Or it could be a lung collapse, right? They could have that pneumothorax. And all of those will lead to respiratory acidosis. So what are we gonna see? Signs and symptoms that they could be in respiratory acidosis, right? So we look for these three things. What am I gonna assess? Decreased lung sounds, change in level of consciousness, shortness of breath. They might have a headache. They might have high potassium. Why? Because they're in acidosis, right? So metabolically, we could have some potassium. They might have some arrhythmias or muscle weakness. Why? Because what's high? Potassium. What does potassium do? What does it cause? Arrhythmia. It has to do with muscle contraction. It can cause arrhythmias. So if you have a respiratory failure patient, this is the clinical picture of what the respiratory acidosis might be, right? That's causing it. Okay, so what do? We protect the airway. We do something to get them breathing more, right? Because they're not going to get rid of that CO2 unless we get them breathing more. So we can put them on BiPAP. We can intubate them if we need to. Or if it's something that's caused by sedation or an overdose, if we reverse it, they're going to get better, right? I can't tell you how many times I have had overdose patient that comes in, and they're blue, they're in acidosis, right? They're complete respiratory failure, give them the Narcan, and within a minute or two, they are up and swinging and breathing just fine, right? We reversed it, didn't even have to get to the advanced stuff. We just fixed the most easy problem, which is they're not breathing because of a sedative factor, and then they're better. Okay. Here's the flip side. If it is an alkalotic problem, right? So we now have a high pH and a low CO2. Okay, so this is the opposite. And that's because we don't have enough CO2. Why? Why do we have that? Hyperventilation, right? Because people who hyperventilate, And the more and more they breathe, the more oxygen they have and the less CO2 they have, because you have to have a balance, and then their muscles start to do this. They start to get dizzy and they start to see spots and they pass out. And what happens when they pass out? Their breathing goes back to normal, right? So breathing too fast, breathing too deep, it could be they're nervous, it could be a panic attack, it could be fever, right? You're breathing pretty fast when you're tachycardic. It could be pain, right? And again, because your body recognizes if your oxygen's too low, your body might think, I need to breathe faster because I need more oxygen. Well, it might take it too far, right? So it could be caused originally by not having enough oxygen, but then we cross over from this to the hyperventilation. Okay, here's another thing that we sometimes do and don't realize it, we can cause this. So if you're on a ventilator and I have your rate too high, or I have your tidal volume, which is how much your lungs fill, if I have that too much, I have just caused you to hyperventilate by me putting in the wrong settings. Okay, so that one's a pretty easy fix. I just change the settings and then I fix the problem. So our signs and symptoms for respiratory alkalosis is again, you think of those people who hyperventilate, right? You're getting rid of too much CO2. We can't keep enough in to balance us. Numbness and tingling, anxiety, feeling very lightheaded, very agitated. They may say their chest hurts. Okay, they might be confused, but these are all signs of respiratory alkalosis. Do you understand the difference between the two? From a clinical picture, you understand a symptom, and I would know kind of what to look for, and you understand why. Yes or no? Couple in the back? Maybe? Rosanna, you good? Okay. All right, so this is important to know because we have to know how to fix it, right? So again, if it's a ventilator, real simple, you fix the settings, okay? We decrease whatever's causing it, or instead of reversing the sedation, maybe we want to cause a little bit of sedation, right? Maybe they need something to help them to relax and slow their breathing down. If you have somebody that is a psychosomatic symptom, meaning like it's a brain thing, it's fear, it's anxiety, it's a panic attack, you can have them cup their hands, you can have them breathe into a paper bag. I like to use a non-rebreather mask, and I put it over their face with the little reservoir, and I don't plug it in. And that way it's sort of like a paper bag. They're just, kind of recirculating it. So whatever you can do to increase their CO2, that's gonna get rid of their symptoms. Okay, so that end tidal CO2, how do we know if that is in the right balance? Okay, again, this looks the same value of what your CO2 is on your ABG, right? 35 to 45. And what it is it lets us know that what you're breathing out is adequate. Okay, so not only oxygen in, but CO2 out. So same thing, if it's elevated, meaning there's too much CO2, we know that we are not breathing enough to get rid of it. If it is low, then we need to increase breathing. Okay, what that looks like on a monitor. And so what Emily talked about is you can get nasal cannula, you can have all sorts of things, and it has like a little orange plastic tab. Is a lot of times what it looks like. And it's as they're using the nasal cannula, as they're using the mask, whatever it is, it goes past this little sensor and it will show you what is happening with CO2. So if this is your baseline, as they breathe out, right, you're gonna see, so if you take a deep breath, you breathe out, it's gonna read the CO2 that's coming out and you're gonna get an uptick, okay? So we have a little bit of a breath and then we peter off the lungs the rest of the way, and that's why we have just a little bit. And then as we breathe in, there's no CO2 and it's gonna drop dramatically. Okay, so this is what we want it to look like, is this up, angled, and down. That's a normal, okay? On the left or the right side here is what happens if it's abnormal. So if you have somebody who has asthma or COPD, they don't have that full lung capacity. Theirs is more of kind of an arch and then a drop off. If you have somebody who's not breathing fast enough, you're gonna have them breathe in and it's a very slow breathe out and a very short time in between, and it's gonna go again. So a prolonged kind of a hat type thing. If they're breathing too quickly, obviously, you're not gonna get a good spike because the lungs aren't filling with with oxygen and breathing off CO2. Or if you have somebody who has apneic, right? They're not breathing enough or they're sedated. Now, why is this helpful for our patients that are coding? Our patients that have apnea, our patients we're doing CPR on. Why would I want to measure their end tidal CO2? Any guesses?
Help determine how the gas exchange is actually happening with rescue breaths.
So we want to see, so with rescue breaths, so Tammy said if the gas exchange is happening. So if we are manually ventilating with the ambu bag, right? We're gonna see this, but it's gonna be about half. Because we're not able to fully expand the lungs, we're not pulling down that diaphragm, we're helping them breathe. So it's gonna come about halfway and go across and down. When they have a spontaneous return of circulation, if we're doing CPR and all of a sudden we start to see this nice peak and drop, then we know that they're starting to breathe on their own. So we watch the monitor, but we can also watch the end tidal CO2 to show us when they're back to breathing adequately on their own. Okay, so you'll see that used during CPR stuff. We want to make sure with respiratory failure, right? We've got all these tools that can tell us what's happening. What is our ultimate goal? We want to correct what's causing it. We want to support their breathing, and we want to correct what's out of whack. That's our bottom line. How do we do that? Okay, we are going to have some medications that you got to know. So the different classes are white and underlined, and then the specific medications are in green. Okay, so our first class of medications that we can use in our toolkit for respiratory failure is bronchodilators. Okay, examples of those are going to be your albuterol, your Atrovent, your theophylline. Okay, all of these are going to dilate and hopefully increase the amount of oxygen that you can get in and CO2 you can get out. Now, beta adrenergic, anticholinergic, these are words that you've heard, right? Anticholinergic, what are our side effects of that? Dry. Red, dry, hot, okay? Our beta, what happens when we have our beta adrenergic with our albuterol? What side effects do we get? Tachycardia, anxiety, shaky, okay? Theophylline is another one. I don't know if you've heard that before. This is a bronchodilator you can use. You can do it either on a nebulizer, or you can actually put it through the ventilator if you want to. Same with albuterol and Atrovent. But because it does have an extra stimulating effect, we want to make sure that you don't use caffeine because it can throw you into arrhythmias much easier. Okay, so bronchodilators, you have 3 different options. Okay, corticosteroids, right? There's 2 options here: methylprednisolone or dexamethasone. Remember, I guess you guys don't do these. The little vials of the Solumedrol that you press down and shake them up. Okay, we can use steroids to reduce the edema. So we want to decrease the inflammation. So we can open it up. We can decrease the inflammation. Okay. Sometimes when we have that hyperventilation, we got to slow everything down. So another option would be a benzodiazepine, right? And you should hopefully be familiar with some of these: diazepam, lorazepam, and azalam. And those are going to help us to make it easier to ventilate if that's a problem, or it's going to help them slow their breathing down. And we can also do analgesics, right? Morphine, fentanyl, hydromorphone, oxycodone, the list goes on. And those can decrease your pain. But side effect, what happens if we use analgesics? What can it cause? Respiratory depression. So we got to make sure we balance, right? So those are the medications that we are going to treat the actual symptoms, okay? If the problem is something infectious, maybe it's a pneumonia that's causing this, we need to think antibiotics. And also if we need to fix the problem with mechanical ventilation, that means ventilator, then we need to go into a whole nother subcategory. So we need to keep them anesthetized, we need to keep them paralyzed, right? So propofol is a good one, etomidate. What else do you guys use for sedation? Versed. See anything else for in the hospital for sedation? No? And then our neuromuscular blocking agents, our paralytics. So what do you see at the hospital? What's the one they keep in the fridge? Lots of like basics. Okay, succinylcholine. Have you heard of succinylcholine? Okay, so Sux is one, vecuronium, rocuronium, all of those are paralytics that you can use to make it easier to put them on the ventilator. Yes.
Are those, would that be like a continuous IV drip or, I mean, propofol is obviously something you keep locked up normally, right? So. Or are those scheduled?
So
Do you know what I mean?
when you
Something-
intubate a patient, if it's in a controlled environment, like the OR, then your anesthesiologist will be there and they'll have everything monitored during the surgery. If it's a patient that you need to intubate, which we'll get to here in a second, then we have a rapid sequence intubation box. It's on a lot of the code cards and that has a lot of the things you need. So it'll have your, usually your Beck and Rock, vecuronium, rocuronium, you'll keep in that RSI. Those are a short-term paralytic, so they don't last a super long time. And we don't typically keep our intubated patients paralyzed long-term. We do more the sedation. So you'll see the propofol drip, you'll see your, I don't know, what else do you see in the ICU? Where are my people? That work in ICU. So we see. What's that? Okay, yeah, so these are the ones that you're gonna do, you can do a long-term drip of those and we'll keep them sedated and we turn it down, check and see where they're at, we turn it back up. Okay. Are you with me so far? Okay, oxygen therapy, this is mostly a review. We want to keep their oxygen above 90 unless what? When do we not want their oxygen at 90? If they're a COPD or if they're a retainer and they normally live about 87, well, 87 is good. Right, so our goal normally is above 90 for their baseline. Okay, again, with COPD, we gotta be really careful. Venti masks are a great option. You've seen those, they've got the different color spacers. We'll look at them tomorrow and those you can hook up to oxygen, but it also mixes with room air so that they're not getting over oxygenated because that causes the lungs to get stiff. Okay, anything that they have to be on a high concentration to get to 90%, we have to really be careful because too much oxygen is bad. It makes your lungs stiff. It keeps your lungs from making surfactant, and then that leads to respiratory distress syndrome. So we want to keep it high. If we're using lots and lots of oxygen to keep it high, we want to make sure that we're keeping a close eye and drop it down as soon as we can. Okay, CPAP, we use that a lot at nighttime. A lot of people have it for sleep apnea, and that helps to keep everything from all the alveoli from closing completely. It improves our ventilation perfusion. So far, so good. BiPAP. What's the difference between CPAP and BiPAP? Two different pressures with BiPAP. CPAP, a lot of people put those on. It's one setting, you hit play, it does the thing, and that's what you have all night. BiPAP, you can have different pressures for breathing in and breathing out, right? With some PPAP into it. Okay, need a break? Or keep going? Keep going? Okay. If we try our CPAP, we try our BiPAP, we try our oxygenation, and we're still getting ABGs that are wonky, we're still getting perfusion issues, ventilation issues, we may go to mechanical ventilation. We may intubate our patients, right? And what we're doing is we're supporting. So if you've ever seen a ventilator, that's what it's doing. It's usually temporary, but it's to support while we correct something else, right? So we can use it for all these reasons. We can use it to give them a break. If they have been breathing to the point they're so exhausted they can't breathe, or if there's an underlying condition where they need extra support, extra oxygen to be intubated. So our most common common type of ventilators are going to be positive pressure, meaning it pushes the air in, right? So it's going to push the air in, it's going to keep everything open, it's going to force the lungs to expand, it's going to force the gas exchange, right? It's going to push those alveoli, get the fluid out so they all expand, and it's going to make it easier for them to breathe. They can rest. Okay? There's another type of ventilator that we use, and this is called a negative pressure. We don't see that often unless you have a neuromuscular condition. So for that matter, it helps to draw the air out. So it's negative pressure. So it can be, you've seen the iron lung or you've heard of the iron lung, and how that works. Instead of a tube down the throat that actually forces air into the lung, it actually pulls the body and forces the chest to expand that way. So it's not pushing anything in, but it's drawing the chest in and out, right? So if you have ALS, anything that was post-polio a long time ago, it really wouldn't do any good to push the air in because they can't push it back out. So you need the negative pressure to do the pushing and pulling for you. But most of the time, what we're going to see is our typical ventilator with ET tube, with the tracheostomy tube, and that's what we're going to see in our ICUs. And when you're looking at your ventilators, okay, there's a thing called a trigger, there's a cycle, and there's limits put on it. So these are the different things that you're going to type in, the respiratory therapy is going to manage, and you need to be aware of. They're going to be a amount of times they take a breath, right? And so there's different settings. If the patient triggers the breath on their own, that's fine. Or there's some patients that they're going to rely on the ventilator to trigger for them. They can't breathe. There's going to be a cycle. How long, how full, how fast do you want their lungs to fill? And then there's going to be a limit, right? So at what point do we put a stop so that we make sure that they don't overventilate or we don't cause the lungs to have trauma? So the first limit that we're going to talk about is a tidal volume, and that is our lungs expanding, right? So if I take a breath, how full can I get in my lungs? What's the volume of air? Sitting right here in class, you're probably somewhere 400 to 550, right? Take a deep breath, that's all you got, right? When you're on a ventilator though, you're going to actually have it a little bit higher. So when I am breathing, when you're breathing, take a breath into your nose, right? You have air that goes from your nose to your mouth to your throat to the top part of your lung that does not do anything with removing oxygen or perfusion, right? It just is air actually getting to the lung. When you're intubated, you actually come right here from the tube. So because we're bypassing this area where air volume's trapped, we actually up it up a little bit. So we usually put our tidal volumes between 500 and 750 to make up for that space where we normally would have air when we're breathing. Okay. Another thing we talk about is FiO2. So if I put a nasal cannula on somebody, I do liters per minute, right? When you're on a ventilator, it does the percent of oxygen, right? So how concentrated it is. Sitting here in our room, we have 21% oxygen, right? That's what we're breathing right now. That's air. But if you're on a ventilator, we can actually go all the way up to 100% oxygen if you're having that much trouble perfusing. So again, just like with the O2 on a COPD patient, we don't want it at the highest level for a real long time. Okay, we want to keep that oxygenation high, but we can't be at 100% for a real long time, or we're going to damage the lungs. So there's different options. We can do all these different types of settings in a ventilator. We can do a continuous positive airway pressure, or CPAP. You can do that when they're intubated. Okay, so that is if the patient's breathing on their own and they're going to trigger it, we can go ahead and give them that little boost, right? Again, it keeps everything open, they breathe easier. We can do bi-level, and that is where we have a ventilator mode that also has PEEP. And PEEP is a little extra burst that just keeps everything open. It helps with the expiratory pressure. The other ones you can use leading up to the ventilator, but you cannot use them with it. So the non-invasive ventilator, right? That's just our ventilation, that's our masks. You can do CPAP, non-intubated, and you can do BiPAP, non-intubated. Okay, but the other ones you use with the ventilator. PEEP is really great. PEEP is an amazing type of, it's positive and expiratory pressure. And on a ventilator, what it does is it actually makes sure that the lungs never empty. It's a little extra at the end, a little extra at the beginning, and it actually increases your oxygenation without making your body work any harder. So it's that little extra burst at the beginning and the end, and it's very useful when you're on a ventilator. Because you can lower the other settings by adding this one. And this one does not change your percent of oxygen. It doesn't change your rate, right? It just assists. So you've got your tidal volume, you've got your percent of oxygen, you've got your other settings you can add. Now we're going to talk about the different modes. Okay, I don't want you to go over the top on memorizing 1,000 things with these, but I want you to understand the difference in the modes. Okay, so if you have somebody, let's say they are a traumatic brain injury patient. Okay, their Glasgow Coma scale is 3. They are not doing anything on their own, and they are in full support of the ventilator. They would be on assisted control. Okay, so that is when, if they would have any type of a breath, the vent takes over to fill all the gaps. So we use this, again, head injury or overdose. Anytime they're not breathing, this does everything for them. Okay, so this is, it does everything. If the patient happens to breathe, that's great, but it's gonna take over. Okay, it's gonna do all of the, it's gonna deliver the same amount of breath, the same tidal volume, the same O2, all of that. When you have somebody that you are, let's say they are a, they had a pneumothorax, right? And they just need to temporarily be on a ventilator. They're still able to breathe spontaneously, right? So we're sedating them. What this does is it synchronizes. So if they breathe, they're breathing most of the time on their own. If for some reason they would drop down, it will pick up and it will start to do it for you. What's nice about this one though, is it syncs between the two. So on this mode, it pretty much is driving the breathing. On the occasional time that they breathe, it will still kind of take over. On the sync mode, what it will do is it will actually, if it starts to deliver a breath and the patient starts to breathe, it kind of shuts down and lets the patient do the work. So it's partial support and it syncs with what they're doing already. Okay, so what it allows the patient to do, it supports their ventilation, but it still lets them breathe and exercise their muscles. This is what we want. We don't want the machine doing all the work. That's more what we think of as life support. This SIMV mode is, we want them to do as much as they can and the ventilator will kind of pick up where it needs to. Understand the difference between the two? Okay. The other things you can add to that, so you have SIMV mode, or you have it's ACMV mode, right? Assist controlled, or you have synchronized. What this does is supports the ventilation without making you breathe. So this is you're breathing on your own, and this will actually support that. Okay, so we use that a lot with our partial, with our SIMV mode. And what it does is that you know you're breathing, but maybe you can't breathe deep enough. Or maybe you're not having the right amount of oxygen. So we use this a lot, especially when we're trying to wean somebody off of a vent. So we let them do all the work they can. We just give a little extra, maybe an extra tidal volume or a little extra oxygen, but we're not worried about your rate. We're just supporting what you're doing. If for some reason you have somebody that is open heart surgery, chest trauma, something like that, we don't want you to take big deep breaths. So in all the other modes, we kind of want you to, right? We want you to do as much as you can. With the pressure control, this is where we don't want anything to change. We want to control everything. We don't want you to take a super deep breath. We don't want you to do anything more than what we have programmed. And so we use heavy sedation to make sure you are totally out and we control everything. So if you think about breathing through a straw with an ET tube, If you are not permitted to take a deep breath, it is extremely uncomfortable, right? You will feel like you are suffocating. So because of that, again, you just had open heart surgery, you've got everything all wired together, or you have a crush injury, right? We gotta keep you minimally moving through here until everything starts to heal a little bit. So they'll keep you very sedated while you're on this mode, and then they'll bump you up. Okay? Every once in a while, depending on where you work, you may find this ILB, independent. So you would work on a lung transplant floor, right? You could actually have 2 ventilators, 1 for each lung. So you could have 1 ventilator that is set up to do pressures in the good lung that you just got, and then another ventilator that's doing the pressures in the lung that's bad, right? So every once in a while, you'll see this. I have never seen it in my career, but I know it exists. So just if you ever hear somebody having 2 ventilators at the same time, yeah, you can't do it.
So in the ET tube, like
It's bifurcated. It goes to 1 in each section, and then you do each one. It's a crazy like thought, but I never really thought about it until like you would, depending on how diseased your lungs are, you may need different pressures for one versus the other. Right? So if they're able to breathe on their own, if we want them to breathe on their own, right? If we want to control everything they're doing, if we want to just control a little bit of what they're doing and support them. Those are the reasons why we would do different ventilator modes. Okay? With the modes come alarms, right? And I cannot tell you how many times I've seen nurses go in and hit silence and they walk out of the room because it's really a loud alarm. Okay? Promise me you'll never do that. Promise me you will never hit silence on an alarm and walk out of the room, because it's alarming for a reason. It's alarming because there is some type of a leak and they're not able to get the pressure into the lung. It's alarming because something is kinked. Maybe the patient's biting it, or maybe the tubing's kinked. Or it's alarming because it's counting on the patient to breathe and they're not. So these are 3 things that we really don't want to happen. So if you walk in and you hit silence and you walk out, there's obviously something happening. Okay, I had a patient that came in to the ER. They were brought in by a private squad, and this patient came in and she was gray, blue, eyes bulging out of her head. She had a tracheostomy and she was hooked up to a ventilator. So she rolled in the door on their cot and we saw gray, blue, bulging eyes. We got her over, we're like respiratory distress and we're doing all the things, right? She was there to get her feeding tube changed. The transport company plugged her into their vent, right? And the alarms were going off the whole time they were transferring her. They just kept hitting silent. They figured it was something wrong with their vent. She did not have oxygenation the entire time from the time they left the nursing home till she got to the ER. So she ended up being like a full respiratory arrest. She just needed her feeding tube changed. She wasn't even coming to the ER. She was supposed to go up to the floor. But they just kept silencing the alarm, right? This is really annoying them in the back of the squad. So just to say, she ended up being okay, but just to say, like, it happens more than you think. All right. Questions on ventilator modes? Are you glazing over? A little bit. All right, so I'm gonna show you a video about what happens when you're on a ventilator. Now, I wanna preface this by saying this is a COVID type thing, and so they do mention the COVID vaccine. That's not the whole point of this video, but just to hear a patient's perspective of what it's like to be on a ventilator is what I want you to pay attention to.
Intubation is simply something we do all the time in our. The problem with COVID-19, however, is in order to intubate you and put you on a ventilator, make you comfortable and not gag on that tube, we would have to sedate you. Well, that requires medications that can affect your body in many ways. long-term, we're really worried about the side effects, memory issues, weakness, profound issues with sleeping and awakening. And we know from scientific studies that longer you're on the ventilator, the chances of a good outcome are much lower.
Those moments just before we add the ventilator, watching our patients struggle to breathe, it's hard to watch as a clinician to see time and time again. This could be your last time that you get to speak to somebody.
Your family's not able to be there with you, and I think that that's the hardest part is, as a patient, you're basically lying there with all of these machines keeping you alive, and you're all alone.
We're pushing air in and you're breathing it back out, and that is uncomfortable. We also have to make sure that we maintain your airway. So we're oftentimes putting tubes down there to suction things out of you. Some people have described it as painful.
Once you have a tube down your throat, you can't eat anymore. You can't go to the bathroom, you can't bathe yourself. And every single day that you lie in bed, that weakness that you get piles up on top of each other.
People are lying in this bed in a coma type state, but part of their brain's awake. They're uncomfortable, they're having machines and catheters placed down, and they're trying to make sense of this world.
I've had people come off of the ventilator and tell me all sorts of different things that are going on in their head because they don't understand what's going on.
I see some of these patients in my office, so they finally got over COVID after many weeks of therapy and all these efforts, but they have trouble going back to work. They have trouble with relationships. They go in looking young and healthy, and they come out looking like they've aged 10, 20 years. What's that like when they get home if they do survive?
In the beginning, people can't hold their head up. They can't grip or squeeze because they're so weak. Sometimes to the point where they can't stand because their ankles are so tight from lying in bed so long. They just feel like the person that they were before they got sick isn't there anymore.
Regret to me is the emotion that I see the most.
So he's gonna continue on and talk about why you have to get the vaccine. I'm not gonna do that. But, I've had different family members, who have said different things about when I was on the ventilator, right? Like I heard everything that was going on around me. Or, I worked with a guy who underwent bariatric surgery. And he actually ended up on, the ventilator for 12 days. And he, when he went back to work, he was an ICU nurse, he said that he so badly wanted somebody to itch his butt, but he couldn't communicate that. And so when his wife came in, he was awake enough to know, like it really itched, but with the tube in, he couldn't communicate. And so when they finally extubated him, he looked at his wife and he's like, now can you please scratch my butt? Right? So just the simple things of like, I'm uncomfortable, my nose itches, like I can't turn, what's happening, that hurts. They're not able to communicate. So please don't ever think that because a patient is sedated, they're not able to hear you. Okay, it drives me bananas when I see nurses go in and they're talking about The Bachelor, or they're talking about their date that they're having as they're rolling and moving and wiping and doing whatever. Instead of going in and being like, today is Tuesday, it's sunny outside, you know, today is so many days till the election, this is what's happening. Just that reorientation every time you go in the room, because they end up with something called ICU psychosis after a while. Because there's constant noise, there's constant light, there's constant activity. So it's very important for us to remember that that patient in the bed, even if they've been there for a week or 2 weeks, it's our job to still make them the priority. Even though they're not talking to us and they're not communicating with us as much as somebody else would, you have to keep that in the front of our mind, right? Because we want them eventually to get off the ventilator and to be able to return to function. So when you are caring for somebody, we are always looking at their airway. We're always assessing their respiratory status every hour or two. You have to hourly document wherever you are putting these settings. So we don't always touch the settings, right? Respiratory can do that, but it's up to us to document them, right? And we have to make sure we're repositioning the tubes. So think about it. If you've got the inline suction and it's laying on your cheek, right? After a while, that's gonna cause skin breakdown, right? where they've got their restraints, where they've got the NG tube. So we want to make sure that we're looking for skin breakdown, moving the tube side to side every 24 hours, doing really good oral care. If we're able to lessen their sedation and communicate with them, we want to make sure that they are, if they're able to lip read, if you're able to lip read what they're doing, able to write. Many times, if you're going to be on a vent a longer term, that's when they do the trach. Then it's much easier for them to maybe communicate. But we can still try even when they have ET tube in. We're going to do frequent suctioning. Making sure that we do a lot of medication. So just because they are sedated, there's different levels of sedation. So if you're noticing that the heart rate's really spiking, if they're breathing very quickly above the vent, it could be something that they just need pain medication or they need an increase in their sedation. We have to look at nutrition. We have to make sure if they're not able to eat, how are we compensating from that? Are we doing a feeding tube? Do we put in a peg tube? Are we doing TPN? And then again, documenting every line, every tube, everything that drains, we gotta make sure we're documenting. My takeaway point on intubation, if you have someone who is on a paralytic, please make sure they have adequate sedation first and often. Okay, because I have seen patients that have a paralytic that is still in their system, like a sedation has either worn off or they haven't given it yet, and they are scared to death. They are crying, there's tears leaking out of their eyes, their heart rate is skyrocket, they're breathing very rapidly. So please make sure we are really advocating for anxiety medication, sedation medication when somebody is on a vent. Okay. Some of the problems that you can have if you're on a vent too long, ventilator assisted pneumonia is a huge one. Right? We've got a straight shot right into our respiratory system. Any bugs in the area can get in there. So we can end up with that. So we always want to make sure their head of the bed is slightly elevated. We also don't want them to aspirate. Barotrauma, that is if we have everything cranked up too high, we can damage the lung. That can also lead to a pneumothorax, right? If we're not paying attention to how high those volumes are and how much those pressures are, we can actually cause the lung to pop. If we have any hemodynamic monitoring, we want to make sure we're taking a look at that and the output. Because they're not moving, we can end up with fluid retention. So always make sure you're doing your eyes and nose, always do your daily weights. And then understanding that there's a lot of stress involved, and most of the time they will end up with a stress ulcer of some kind. They're not putting food in their system, they're not eating or moving, we're cranking in all these different medications. So we usually put some type of a H2 blocker or carafate or sulfate in there. When we're looking at a ventilator, really want it to be temporary, so we have to decide, is it something that we're going to wean right now, meaning you're on the ventilator for 48 hours after surgery, or is it something, COVID, where we're gonna be on it for a long period of time? So depending on what our plan is, we can either use two different things. So if it's a long time, we're gonna use one of those, the synchronous or the pressure support. If it's a short amount of time, we might even put them on a vent, but just leave it on a CPAP type setting. Okay. If for some reason you are starting a weaning protocol and your patient starts to have stridor, airway obstruction, or their cough isn't working after you've taken out the tube, make sure you get them right back in, intubate them right away. So always, always, always make sure you have re-intubation equipment available when you have extubated somebody. Okay. If at any point in the weaning process you see any of these things, go back to what you were doing before and get them reevaluated. Okay, so any sign of distress, there's the list. Make sure that you are stopping what you're doing, right? Again, this is an NCLEX thing. If something is happening, we stop what we're doing and we get a further instruction. Okay. Every once in a while, you will have a terminal wean case. And that is where you decide to withdraw support, withdraw the ventilator, and they're not expected to survive. So if that is happening, we try to get them to a room that is large enough to accommodate a family. We try to make sure everybody staff wise knows what's happening so they can support. We have hospice there. So all the different legal things are done. So if you get in a terminal meeting situation, just make sure if it's your first one, that you get your charge nurse or you get a support person on your unit that you worked with before that's done it, and to kind of walk you through, because it is distressful. I mean, we're there to save people. Making the decision to withdraw support is not always easy. All right, practice questions. We like practice questions because that means that we're done with content for a minute, right? So if you're caring for a client with respiratory distress, tell me which of those are early signs of hypoxemia. All right, E and E. So pale skin, elevated blood pressure, right? The body's trying to compensate. Infusion, bradycardia, and hypotension are the late signs. Okay, so if you're already starting to see the heart rate drop and the blood pressure low, we're already at a different point. You're assessing a client on a mechanical ventilator with a tube. What do we teach? D. So we assess breath sounds every 1 to 2 hours. And not only we assess them, what do we do with that assessment? We chart it, we document it, absolutely. Do we use vest restraints on our patients? What kind do we use? Soft wrist. I love on TV when they show a patient who's intubated and the patient's like sitting up and gesturing with their hands and writing. No, we want to make sure they have soft wrist. Okay. How often do we document our ventilator settings? Every hour. And then what about tube placement and angle of the jaw? We do it at the teeth or the lips, and we do it in centimeters. So on that ET tube, there's little markings, right? And those are all centimeters. So you'll see it documented 21 at the lip line or 21 at the teeth, whatever it is, and that, so everyone consistently knows it's in the same spot. It didn't get pulled. Okay. Now we're looking at modes. Ones of their respiratory muscles. B, C, and D. So our SIMV, our CPAP, and our pressure support. Right? Assist control, we know that that is full life support. And the independent lung, we know that that is 2 ventilators, right? So we're doing all the work for those as well. Okay. Take a breather. And then we'll assess where we're at as far as if we want to do ours or we want to have that recorded and watch it later. So take a breath, take a break, and then we'll go there. All right, this is not going to take very long. He's made great. You're watching these on great. She's going to talk about arch. So this is something that I think we see more and more. And that is acute respiratory distress syndrome, right? So what we've talked about up to this point is acute respiratory failure. This goes beyond, and this is a form of acute respiratory failure. My colors are really bad, down here at the bottom. This is the important thing, and unfortunately you can't see it. It does not happen on accident. It's not a primary. You don't get like just diagnosed with ARDS. Something has happened that has progressed to acute respiratory distress syndrome. So this is an inflammatory response that happens. So if you have been on the ventilator a long time, if you've had pneumonia, if you've had some complication that has further damaged your lungs, this is what you can get to, okay? And this is damage to the alveolar and capillary membrane. Okay, this is where fluid then enters into the alveoli and the surfactant. So the stuff on the outside of the lung that makes it nice and slippery so it can expand and decrease as you breathe, it starts to not work. So when you have that happen, when you have extra fluid in the alveoli and your surfactant's not working, your lungs get stiff and hard and they don't collapse and expand. And as a result, you end up with lots of issues. So if you have someone on a ventilator for a long time, especially at 100% oxygen, this is what happens. The lungs get stiff to the point where even you're putting in as much as you can and you're pulling in as much as you can and the lungs just don't respond anymore, right? It's like it's a scar tissue type thing. So usually after some type of injury, so whatever happens, within 24 to 48 hours, you'll see this develop if it's going to. So this is where you go from your injury, then you start to develop some distress, then you start to develop some failure. So all the things that you would see, depending on how severe the ARDS is, all the assessment findings will be there. Okay, here's a video link that goes into it, and it actually does a little animation, which it actually explains what it is and how it's formed, and it helps to click a little bit. I'm not gonna waste your time. But here's the difference. Here's the difference between respiratory failure and the ARDS. So it's called your PaO2, FiO2, right? So we know PaO2 is your oxygen, FiO2 is the percent of oxygen. So how you know you're in ARDS is if your O2 is not responding to the percent of O2. So if you're doing that, you do it as a math problem, right? You put your oxygenation on top, you put your percent of oxygen on the bottom, and if it comes out to less than 100, you have a 45% chance of mortality. So all that means is your lungs are so stiff that no matter how much oxygen you're throwing at them, your body's just not using it. Okay, so it's the PaO2, FiO2 ratio that tells you how bad your ARDS is. Okay. So you do not cure this once it reaches that point, right? All we do is support it, and then we reverse whatever caused the respiratory failure in the first place. So it's not like, oh, here's the treatment plan for ARDS. The treatment plan is fixing whatever happened upstream, okay? So you will have to be on a ventilator most likely, and you're gonna have to work to get your oxygen higher and get your percent of oxygen lower, right? Because again, the more oxygen you're pumping in there, the more stiff those lungs are getting. So go back to what caused it in the first place, start fixing that, and then the way to treat the ARDS is then fix that so you can change the settings. Okay? A few things that you can try. You can try steroids. They've had some luck with inhaled nitric oxide. Putting that through the ventilator, that has proven to kind of loosen things up a little bit, improve your oxygenation. Or you can try surfactant therapy, which are different ways to address not the issue, but try to get the lungs a little more compliant. And making sure that all of their fluid balances are good, because as the fluids start shifting into the alveolar space, we end up with increased lung issues. So very complex, very difficult to treat, but I want you to understand, number one, how you find out if it is ARDS instead of just respiratory therapy or respiratory failure, and then knowing that you have to use the upstream factor. So when we do our treatment plan, we are going to do really careful status of our ventilation. We're going to watch those ABGs. We're going to do all the things we did on the ventilator with suctioning and that type of thing. We have to make sure we are clustering our care so they can rest, because we know that they're already super compromised. So this is not the time to go in and like every 15 minutes do your assessment and do this and do that. Cluster your care and let them rest. Okay, that's what we have to do. Careful monitoring of your hemodynamic status and urine output, daily weights, again with that fluid shift, and then your lung assessment. So everything you did up until the respiratory failure, and then we just kind of kick it up a notch. Okay. Questions on what ARDS is? You'll hear it, there's a lot of NCLEX questions on it for some reason, I don't know why, that's a topic they kind of pick, but understanding the difference of progression is what is gonna be the most important thing. So a couple more practice questions and I'll let you go. Why would we give Vecuronium to a client with ARDS? Okay. B, right? Because they are so compromised and those lungs are so sick, this would be a reason why we would use a paralytic for somebody on a ventilator. Okay, because if they are perfectly still, we can do the work for them and we have better control over what's happening with them. Okay. What action do we take? Dyspnea, absent breath sounds, is their blood pressure okay? Okay, heart rate? Elevated, respiratory rate. When we did mass disaster, remember we did that triage case study? What were we concerned of? Rest above what? 30. Was it 30 or 33? It was 30. So this is 38 and a stat of 92. Just looking at that, if I just looked at the vital signs only, would I be concerned? Yeah, we still have a stat of 92, heart rate's a little high, respiratory high, but then you match that with the symptoms of dyspnea and the absent breath sounds. And yeah, we're gonna go with C, which is we're gonna put on the oxygen first. When we do our priorities, don't ever get those mixed up, right? Yes, we need a chest x-ray, yes, we need to have IV access, but always doing ABC, right? Questions on lung stuff? Tomorrow.